Hello, everyone. Welcome to another POCUS VMR. Today we have a really special guest, Dr. Renee Dversdal. She is a professor of medicine and academy hospitalist of Oregon Health and Science University, and she is the director of Point of Care Ultrasound. We are really happy to have her. I think it's her first time on POCUS VMR. Do you want to say hello and tell us a little bit about yourself?
Yes, hello everyone. You're very kind, Vig. Nice comment. So Renee Dversdal, and actually, so I'm very excited because at Oregon Health and Science University, I'm now the medical director of simulation, which means that I was able to get out of the way for one of my mentees to actually take over that role. So sometimes, um, POCUS is my true love. Don't tell anyone I said that. But it's nice to sometimes be able to sponsor your mentees to move up into other leadership roles. So, but I still love POCUS. And I was saying this is my like everyday background. So we'll make sure we get some nice pattern recognition in addition to our excellent discussants conversation.
Amazing. And you want to share with us what you like to do outside of medicine?
Oh, yes. Gosh, I'm afraid I really am not very good at hobbies right now, but I want to get back into scuba diving. I really enjoy scuba diving and I haven't done it in a long time. So that's my new like thing. And I feel like I should learn something else fun and outdoorsy. So I might want to get back into golf or something. I don't know. I joke I'm a terrible Oregonian. I don't bike to work and I don't camp and like I'm just a bad Oregonian.
Amazing. I think we can start with the whiteboard and go for the case.
Excellent. And what I did was I pasted in I'll paste it one more time for anyone who joined again after I pasted it. But this is actually from a human diagnosis case where we wanted to make sure um, we just wanted to emphasize POCUS as much as possible. So this was back in 2019 or 2020. So that's just for anybody that wants to look at it in their phone. And then I'm going to go ahead and walk through the aliquots and let our folks here do their magic. So our patient is a 60-year-old female, and she is presenting with acute and chronic shortness of breath with a cough. So she says, and I don't know how tell me if I talk too fast. But she says normally she can walk 1 block. And for the past like 3 days, it's gotten worse and worse to where she's dyspneic just going down the hall of the bathroom or even doing dishes. Um, she has had a cough with a little bit of yellow sputum for 5 days. And we're going to say she's here in Oregon and has clear rhinorrhea like the rest of us with our allergies. And then some stable lower extremity edema. And then no chest pain, no fever, no other complaints.
Amazing. Yasmin, do you want to share your thoughts?
First, first of all, thank you so much, Dr. Dversdal, for bringing this amazing case. For a patient of this year with acute and chronic shortness of breath and cough, I'm framing this as there might be, for the etiology, for the onset, I would think, is this a cardiovascular issue, a pulmonary issue, and my third bucket would be miscellaneous. But I would like to, for this subacute presentation, focus on cardiovascular and pulmonary issues. Why? Because you're telling me now that she used to be able to walk 1 block, but for the last 3 days she's been dyspneic. I'm thinking, does this person have any past medical history or predisposition to have congestive heart failure? Why? Because I'm also seeing unstable lower extremity edema. And I'm thinking if this is bilateral, when we have bilateral edema, we have to think of systemic causes, lung, kidney, and heart again. So there's this convergence of cardiovascular and pulmonary issues on the shortness of breath, and also on the bilateral lower extremity edema, we have also this convergence of these three particular organs. So that would be my first step on this patient. I would have started talking about red flags, but this patient came here to the ED, I'm thinking. So I'm thinking, okay, she's not in an emergent situation. So that is my first framing, like cardiovascular and pulmonary issues. And in pulmonary, I will think, could this be pleural? Could this be parenchyma? Could this be an airway issue? But yeah, those are my thoughts. What are your thinking, Ibrahim? I would definitely love to hear you.
Well, thank you, Yaz, for actually putting in the framework for me. And thank you to Dr. Dversdal for this amazing aliquot. So I think just like Yaz mentioned, I think the really the triggering symptom that this patient seems to have is the shortness of breath. And then once again, just like Yaz mentioned, I think shortness of breath, really when I think about it, I think of the chest as a whole. And so in the chest, there's the chest wall, and then there is the heart itself, and then there is the lungs. So whatever affects either of these three entities can result in shortness of breath. So when it comes to the chest wall itself, so things could be neuromuscular diseases could result in shortness of breath. So something like Guillain-Barré syndrome, for example, or ALS. And then there's also anatomical variations that can result in shortness of breath. So something like kyphoscoliosis or obesity, for example. And then when it comes to the lungs, I think just like Yaz mentioned, we need to really look into the anatomy of the lung itself. And so you have the airways. And so in the airways, I can think of things like asthma or bronchiectasis. Then there's the parenchyma. And so in the parenchyma, I would think about interstitial lung disease. And then there are the alveoli. So in the alveoli, I remember we once had a teaching pearl where if you want to think about the etiologies that can result in shortness of breath and are manifesting in the alveoli, just think about fluid. And so fluid, you can have blood, you can have pus, or you can have edema, which are accumulating within the alveoli. And then when it comes to, and then there's also obviously the pleura. And so whatever is accumulating in the pleura can result in shortness of breath. And then when it comes to the heart, so the heart, I think about it in the layers of the heart. So the myocardium, the pericardium, and the endocardium. And so for the myocardium, I think mainly about heart failure or myocarditis. Whereas in the pericardium, I think about whatever is accumulating in the pericardium. So if you have constrictive pericarditis, where the pericardium cannot distend, or if you have fluid due to pericardial tamponade. And then for the endocardium, really any disease that can result in endocardial manifestation can result in shortness of breath.
Oof, amazing. Really great dissection for this first aliquot. I think we can go for more information about the case.
All right. And I threw in a fun fact. Somebody commented on Dr. Mansour, the frameworks for internal medicine. And Andre and I actually were co-med students and met at our white coat ceremony, like the first day of med school. So we go way back. Okay, so next I will give you the past medical history. Of course, nowadays you're getting it like in the one-liner usually, but it's a little bit of a pet peeve of mine when the one-liner includes like, you know, hypertension, I don't know. I just feel like everyone has hypertension, hyperlipidemia, and sometimes the one-liner is so long it like, has their dog's first name in it. So I'm like, I guess one of my things to you is use the one-liner to you all of you, everyone learning. The one-liner should help frame our current presenting problem, not like their entire past medical history. But I gave you no one-liner here, so now let's actually give you some things that probably would have shown up in the one-liner, which would be that She again is a 60-year-old woman, and she also has so COPD on a LABA, and then ischemic cardiomyopathy. So she had 2011 or 2010, whatever, remote drug-eluting stent to her LAD. So she has this ischemic cardiomyopathy with this coronary artery disease, and her last known EF space limitations in humans. So we're going to say, 6 months ago was 40%. And we would say this is old before we were classifying morbid obesity, but just morbid obesity, and we'll say BMI of like 40 to 45. So that's your PMH there. For meds, let's just say like usual. So we already specified the LABA, and then kind of your classic cardiac package of beta blocker, statin, furosemide, 40 daily, and aspirin. And for family in kind of everything in this middle column, again, we're going to keep it pretty tight. So family history, none of that stuff is I would say contributory to this presentation. So we'll just focus on the left stuff.
So yes, please be my guest.
Are you sure? Sure. Okay. I think I can start with the COPD. All this past medical history is quite rich, actually. And thinking about COPD, we know that it can be an exacerbation. This shortness of breath, this acute or chronic shortness of breath could be very well an exacerbation of COPD. But we have to also think about the complications of COPD. And one of them would be, for me, the first I thought about is cor pulmonale, which is the right heart failure. She also has ischemic cardiomyopathy, and she has a ejection fraction of 40%. So I'm thinking she already has this predispositions to have a congestive heart failure, specifically from the right heart. So that's what I will be focusing on right now. I don't think I would do anything else on her meds. Although I'm thinking if she has an exacerbation of COPD, if I was her primary care practitioner, I will think, well, maybe should we escalate the treatment if this is just an exacerbation? But those are my thoughts, those two. What are you thinking about, Ibrahim?
Yeah, so just like you mentioned, I think we have to go with the most common, and in someone who already has a prior established diagnosis of heart failure, probably the first thing that would come into my mind is an acute exacerbation of heart failure. And then just like you mentioned, they have COPD. So with the sputum and the shortness of breath, this could also be an exacerbation of COPD. So those would be the two diagnoses that I'd have in my mind at the moment to rule them out. At the time being, I feel that the second aliquot has also helped us in ruling more serious causes. And so just because we know now a lot that about the patient's history, we know that this is not something new. This is something that has been going on chronically for a period of time. And whatever is going on right now is exacerbating their underlying condition. So I'd be less urgent, but at the same time, I think I agree with you with what you've mentioned. Yeah.
And as we are in POCUS VMR, where you would like to do POCUS?
Yeah, so honestly, for me, probably the first thing that I'd do is an echo for this patient because I'm thinking mainly about the heart with the lower lymphedema and the acute on chronic presentation. But yeah, I'll keep the lungs for you.
Yeah, definitely. I think heart and then lungs I would definitely look at. So try not to anchor, of course, because this is a POCUS morning report, but definitely think about there's something going on in the heart, and I would like to see what is it.
I love we're seeing lots of great stuff in the chat. And because I'm like one of the OGs of internal medicine POCUS, I will always give you a physical exam as well. Because in, over a decade ago, when you'd be like talking about this stuff, everybody thought that you were trying to replace the physical exam and bring something in between you and the patient. And so it's very important to me to show our newer and older generations of doctors that this is another piece of information. We're not replacing anything. We are adding and getting a more comprehensive exam. So, I mean, sometimes the ER folks will joke around and call their stethoscope the wheeze detector, but you can also, it's not, we know it's not as sensitive as POCUS for a pulmonary edema, but it's important to listen. So I just don't want anyone to walk away saying like, Dr. Dversdal said, skip the physical exam. So I'm going to give you, excuse me, our classic physical exam first. And then we can talk through our thoughts on the classic physical exam, and then we'll layer on some POCUS and talk about how that moves our clinical reasoning, okay? So we have a patient who is afebrile. Their respiratory rate is 20 breaths per minute. They're satting 89% on room air. Their heart rate is 95 beats per minute, and the blood pressure is 148/88. We hear distant breath sounds with a few crackles at the bases and a mild, mild expiratory wheeze. In terms of the cardiac auscultation, you can't hear any murmur or S3. Unable to appreciate JVP due to body habitus, although hat tip to Andre Mansour, he's like, y'all just aren't trying hard enough. And a lot of times that's true. But I've never had a, we'll all joke around that I've never had an IJ I couldn't find on POCUS. And she has 1+ bilateral pitting edema to below the knee. And just since it's not exciting, I'm going to say her EKG is stable from prior, no new changes, previously appreciated Q waves. And actually, I will also, because this would be done always by the time you see them in the ER, her portable AP chest radiograph is a suboptimal exam due to body habitus and portable AP technique. So that's all the data I'll give you, and then I'll show some POCUS.
Ibrahim, you wanna give your thoughts about the physical exam?
Yeah, thank you. Thank you, Adab. So I think just to summarize everything that has been mentioned, so this patient may have an elevated IVC, but we still don't know. But the findings that we're sure of is that they have bilateral uh, um, lower pulmonary crackles, and they have 1+ edema, and then they have an expiratory wheeze. And when I try to actually, link whatever physical exam findings they now have with their underlying already diagnosed diseases, including the COPD and the heart failure, I don't see them really striking in a sense that they seem to go on with acute exacerbation of heart failure. I guess just like Dr. Dversdal mentioned, I think the IVC would truly be important in actually understanding the patient's fluid status. And based on that, it would also dictate initial management of this patient. And so I'm excited to learn more about what the POCUS has shown for this patient. But I do wonder if Yaz has other thoughts as well.
I think you had an amazing approach, my friend. Framing this again. I would like to focus on the 89% of oxygen saturation in room air. This is telling me from the exam that there is an issue in the perfusion, ventilation, or diffusion. So what do I mean by those three buckets? Meaning that we already know that the patient has COPD, so common things being common, this might be this hypoventilation issue, an obstructive issue. But we can also think about, wait, could there be an issue in perfusion? Another very urgent thing that my mind goes to when I see a low oxygen saturation in room air is pulmonary embolism. So I just have that on the back of my mind, trying to correlate it with the other findings. And knowing this, distant breath sounds and crackle on basis, I'm going to focus more on hypoventilating issues. So that would be my approach on this side. Like, I would like to know what is in there. Is there liquid edema? Is there pus? Is there something else that causes distant breath sounds and causes this hypoventilation? So that is my question right now from now on, that I'm going to try to crack with the next findings on labs and imaging. But thank you.
And then, Yaz, I loved how you actually commented on the oxygen sat in this patient. I think if I also had to comment on that, I think I'd also ask about the patient's baseline saturation because they have COPD. So I do wonder if this is a large variation from what they're used to, or if it's a small variation. And I think this will dictate, basically, just like you mentioned, looking for a more emergent underlying cause like a PE.
Yeah, completely agree with you. And Dr. Vinesh did a great observation about the baseline of a patient with COPD. What would be, what is her baseline? That's something that I completely missed, and I think that I should have focused on too. That she already has COPD. We don't know for how long, so maybe this is her baseline too. So I'm thinking again, if I were her primary care doctor, think about like oxygen therapy because she's already 89%. If we should start it already, all those nuances. But I'm very curious now. What else does this patient have?
Okay, so I commented in the chat, no like home O2 or anything. Let's say her normal stats are like, 92-ish. And then the labs were, we'll say, just kind of like boring labs, negative trope. So when we think about lung ultrasound, or if we have I love our differential diagnosis here. We're thinking about multiple different, I like how we broke it down. And I could do like 4 hours on lung ultrasound alone, but we're just going to try to focus. And this is why it's my background. I love a very simple wet dry approach. I'm kind of old school. And so some people will be like, oh, I don't know, like we were learning at Society of Hospital Medicine, we were learning like the medial meniscus of the knee, and that's cool. But I'm more like big picture, like, is there giant fluid or not? So we're going to keep it to what I think is like the most useful for just basic lung ultrasound all day, every patient, wet versus dry. So I'm going to, let's see, share my screen here. So I'm going to show you what the lungs look like all over. And we'll just maybe do desktop one here. So we're going to say that the lungs in all of the fields, and we'll discuss not lung fields. One of the radiologists at OHSU would say fields are for cows. So that's like burned into my brain. He also would yell at you if you said the aortic knob. He would like absolutely yell at you. So and Andre Monsour would remember this. Yeah, for sure. We all had the same guy who would yell at us. So we have up at the top here, this is our pleura, and we see these little white lines, or these bright white lines, going through the far field. And so I'm going to tell you that you see this all over in your lung zones that you're looking at. So we'll pause right there because I want to talk through, and then I'll give you more information. But like if that's all you had. One example, we've been doing some teaching with nurses in nursing homes, patients discharged with heart failure, and lung ultrasound. This pattern does not take an MD or a DO or an MBBS or anything else. This pattern is easy to see. And so there actually was even a study, nurses on discharge looking for B lines versus IVC, et cetera, patients on discharge with, sorry, I gave it away. I am rusty at teaching a virtual discussion, y'all. Anyway, this pattern's super important, and I'm emphasizing it so much because nurses, MAs, EMTs, anyone should be able to do it. So now that I've said what it is, I will go back to you all to discuss.
Yaz, I'm not sure if would you like to go first?
Yeah, definitely. What I was looking at there, I tried to remember that for me, it's like a stepwise approach, as Dr. Ravi has taught us in our POCUS sessions. When we see these kinds of images, to look for A lines, B lines, to also look at the sliding of the pleural, like this. I have read some literature pieces that says there's like seashore signs. They really like calling it this way, and I think it's very poetic. I think that in this case, to determine if we have a B line or an artifact such as a comet tail line, comet tail sign, it would be looking if the lines go all they extend towards the lower side. I'm so sorry for not saying the correct terms. I'm pretty sure that in English they are different. That's my first thought. And if we are situating ourselves in the anterior chest and we see B lines, there are most likely a pathologic B lines if we are in the anterior chest and these go all the way down. So, but yeah, I didn't have, if I'm being very honest, I didn't catch, like I couldn't have a lot of time to see the sliding and
I'll play it again. Don't worry. You did great.
Okay, thank you so
Yeah.
much. But that's my first approach. I would definitely love to hear what your thoughts are, Ibrahim.
So thank you, Yaz, actually, for the wonderful explanation of what is most important to look at when it comes to a lung ultrasound. So I absolutely agree with you. I think the three most important things that we need to look at is basically the pleura, and just like you mentioned, the sliding is important. And so if there's lack of sliding, I think about something happening in the pleura itself. So something like a pneumothorax. Because basically what we see on the ultrasound, the small dots that we see at the pleural line is basically the two pleura going against each other. So if they're not going against each other, we see them mostly as like straight lines without the small dots. But for this patient, we saw the dots. I think I've seen them. So I don't think that there's something happening in the pleura. What's truly interesting in this patient is the A and the B lines. And then just like you mentioned, Diaz, so the A lines are basically the lines that would be horizontal, and then the B lines are the lines that would be vertical, and each of which actually correspond to different underlying etiology. And so if a patient has an A line, which is basically a horizontal line, it could be a normal finding, but it could also indicate an underlying disease such as COPD or asthma, or I believe also a pneumothorax. However, if a patient has the vertical lines, which are the B lines, which in this case this patient had, then we mostly think about fluid in the lung, and so pulmonary edema. And so if I had to comment on this patient's lung ultrasound, I'd probably say that they have some sort of pulmonary edema going on.
I love it. Excellent discussion. So if y'all are okay, we'll do just like a little 5-minute, some quick slides on how I think about my lung ultrasound. And then later on, we can come back if we have time. We'll talk about the clue exam, which is my very favorite heart exam. I tell my patients, I'm not a heart doctor. I'm not a sonographer. I'm not a radiologist. So I really like to focus on these binary yes/no decisions that help guide me at the bedside real time that we know perform well. And so there's so many cool things you can do. we just were talking about the Vexus, and Abhi Karatala at NephroPocus is amazing, and he's so good at the Vexus. I'm still trying to figure out how to translate that into my own clinical care. So what I like to teach to all comers is like your well-performing binary yes/no decisions to then you're the doctor. So you're going to take that information and model your care with it. I like to say that B-lines are like ultrasonographic crackles. You have to be the doctor to figure out what those crackles are from. So I will share my screen again. And notice here, I love how you grabbed, on our whiteboard, I love how you grabbed the screenshot. B-lines are hard to quantify, right? And it's hard on a still. I feel like I can never get a still shot that actually has them. So it's just a nice example of why clips are really great for B-lines because they kind of are moving across the screen. So, okay. So we'll just go back to my desktop here, and that's for a little bit later. Okay. So this here, I like to just contrast, like the lung is kind of different, unlike our normal, like the kidney looks like you would think a kidney would look like. So the lung is all about artifacts. And for many, many, many years, it was in Harrison's textbook of internal medicine that the lung was not amenable to ultrasound. Air is almost impermeable, like 99.9% reflects back. So all we're seeing is we're seeing a reflection at the pleura. This is Giovanni Volpicelli, like who I first learned lung ultrasound from. Always has this Narcissus looking at himself in the mirror of the pond. So we're just seeing a mirror and we're seeing artifacts, and then we have to know how to really interpret those artifacts. So I love how you all said pleura in the pattern. I'm going to add in the ribs. So these are called Volpicelli zones. There's different protocols wherever you are practicing or in med school or residency. You're going to learn what your local people do. Do they say right, 1, 2, 3, 4, left, 1, 2, 3, 4? Do they do the blue protocol instead? Do they say 1, 2, 3, 4, 5, 6, 7, 8, etc.? So I encourage you to figure out what your local site does. So you're using the same language. But big picture, we don't just auscultate in one spot, right? I only hear what comes to the chest wall there. So I also have to insonate. I have to ultrasound in multiple areas to get an idea of what's going on around the chest. So I add in the ribs. I like to say the ribs are the North Star to find my pleura. So we're going to look for our ribs, our pleura, and our pattern. So the ribs are the North Star. And the reason why it matters is if you use a high frequency linear probe like this, I'm going to see fascia in different tissue planes. And so I don't ever want someone to see this up here and be like, oh my gosh, that's a pleural line that's not moving. But when I see my rib with a shadow behind it, I know that's my North Star to the pleura. So for me, I teach people find the ribs, then the pleura, then the pattern. Okay. I like to think of the normal lung as just a balloon. It's just a balloon full of air. And so the Neelam Soni book, Point of Care Ultrasound, is phenomenal. I definitely recommend it. And so what happens is like the ultrasound beams are cruising through and they're all happy and they hit this air. 99.9% of the beams reflect, but the pleura, they don't reflect from the pleura. The pleura is like a piece of plastic wrap. It's so thin. They reflect from air underneath. And so, so where Ibrahim, you said you could actually see A lines with a pneumothorax because all you know is that it's air under your parietal pleura, right? So you were totally correct. So we get these nice reverberation artifacts, and this is what Yasmin had said, like A for air, or one of my colleagues, he says A for across. So A for air, A for across. So these are our A lines. They're horizontal, and it's important they repeat at the same distance from the transducer. And they're just little ping pong, little reverberation artifacts. And they're equidistant. And this is our normal, I don't think of it as like wet versus dry. I'm thinking of like a ratio of density. So this is like normal density ratio. we already mentioned they can be physiologic or free air. I moved my slides on pneumothorax back. If you don't see the shimmering, as they mentioned, then you have increased your suspicion for a pneumothorax. And there's other things you can do to find that, that we're just sticking with A versus B though here. So again, our nice little A lines there. So you have to be, so this is where learners sometimes, they know the patterns, but if you see no pattern, you're like, I don't know what to do with that. So if you are off axis, your ultrasound beams are going to reflect or refract. So we have to get to be perpendicular. So this is just non-diagnostic. If you tell me there's no B lines, I'm going to say no. That means nothing. So this one you can say there's no B lines, or rather there is an A line pattern. So when I'm teaching people, I say we have to slide it, rock it, and fan it. Kevin Pyro calls it, he's like, it's like bop it. So slide it, rock it, fan it. So we slide until we are in between rib spaces, okay? And my shadows are on the side. Then I have to rock it until my pleural line is flat. And you can see here, our external anatomy, whether it's clavicle, pec, breast tissue, makes us feel like the chest is flat, but really the chest is rotating and also diving under that clavicle. So I slide it till I'm in between the rib, and then I rock it until my pleural line is flat, and then I fan it side to side until I'm now perpendicular, head to toe and side to side. And so yeah, so this is again, Kevin always does the bop it. I'm too old for this. You are probably too young for this. I don't know. But that's how we do it. So we slide it till we're in between the rib spaces, rock it until the pleura is flat, and fan it until you pick up our A lines. Everything that I learned, I kind of learned by like, I was frustrated trying to get the perfect view. So I was like, all right, what's the imperfect view and how do I correct from there? So that's how I like think of it backwards almost. And then the next thing, moving on to our B lines, I think of B lines almost like a sponge, right? So it's light, it's air filled, but it's slightly more dense. It's not full of pus yet. It's not frank fluid pleural effusion, but it has more density. So I picture these as like our little interlobular septum. And again, these are our B to the bottom. So B lines must go all the way through the far field. And this is where it's this reverberation artifact due to this increased lung density. We still don't know exactly why. There's a couple different theories. We had said before, like blood, pus, water. So transudate, exudate, blood, collagen, etc. And this is our, if you want to like kind of, in the older papers, they call it like lung interstitial syndrome. Oh, apparently that gives me, well, it happened once. Maybe I'm crazy. I thought I saw it. Yeah, whatever. These new effects in Zoom are throwing me off too. And they do increase with decreasing air content. So this would be an example of like a normal, we don't have fluid in our alveoli, right? It's air filled. So we're going to see our A lines. And then as it starts to fill in a little bit, we're getting this increasing, like our interlobular septa we're getting more and more dense, and we're getting some B lines. And then over time, we get almost this whiteout as the alveoli are like full. It almost like coalesces into one. And so the big picture here, above all else, I love clinical problem solvers, right? We talk about our clinical reasoning. Again, what is our pattern? It's so important. Is it diffuse, 2 or more zones, and bilateral? That's going to make me think of a systemic process or something going on, not just in one lung zone, versus our focal right here could be a pneumonia. It could be a pulmonary contusion. I've actually seen those from a seatbelt sign, just B lines right here. And I didn't know why the patient was in the hospital. So again, differential diagnosis is key. It's just like crackles. You have to be the doctor to figure out why. And then one last little piece. These here, you might be tempted to call these B lines, but this is maybe only, let's say like 3 centimeters. So I would want more depth for you to show me it goes all the way through the far field. Different textbooks will tell you different things about the minimum depth. For me, like 12 centimeters is fine, but just like to throw that out there. So again, they can be from several etiologies, and you have to be the clinician to put it all together. Okay, so yeah, we talked about that. I'll kick it back to you all to discuss, and then I can layer on a little bit more of the clue exam when we are whenever.
I think now we can ask Ravi if he has something to add and
Yeah, okay, perfect.
I know so far, Yasmin Abraham had been doing really well as far as considering the lung and the heart as a unit, and with this patient's previous history of reduced ejection fraction, it's highly likely what Yasmin mentioned, what's common is common. And then just looking at the lung ultrasonography there, you do see the B lines. So it's all you have to at least see three or more B lines, sort of like the cosmic rays Yasmin had mentioned. And they should be from the pleura all the way to the bottom, like Dr. Dversdal had mentioned. And these have to be systemic, right? So that would have to be a systemic process, like pulmonary edema. If it was pneumonia, now what was it interesting? The first aliquot, what was mentioned, cough or yellow sputum. So if this was a focal pneumonia, we would see it in one zone. So it would be in one lung, maybe a lobar pneumonia or something like that. You may also get hepatization of the lung on ultrasonography. But here we get confluent, like B lines, and it's very much a systemic process. It'll be either one of ARDS, interstitial lung disease. You could have a diffuse pneumonia, viral pneumonia, something like that, or pulmonary edema. So one of those fits this patient. And I guess I'll toss it back to you. But I think the next thing would be to see how the heart is, and if the heart is showing signs of congestion, and maybe the IVC. So I don't know if Dr. Dversdal has those images for us. Anything else, Ibrahim, Yasmin, you want to mention?
I really don't have any other thing to mention. Thank you, Ravi. But I think, yeah, so just like you mentioned, the pneumonia, I think should probably be at the top of the differential as well. I do wonder if, because this case is presented on CP solvers, if it's going to end up being idiopathic pulmonary fibrosis, but I hope not.
Completely agree with you, friend. I don't have anything else to add.
So this one, it's not a zebra, it's not a trick or anything. This one was actually just this patient had her family in town for 3 days, and she didn't want to go pee all the time, so she skipped like 3 days. But before last week, she skipped her diuretics. And because we're going to pretend that we'll talk a little bit more about heart ultrasound, but even if you only know, and this is part of my mission in life, is like, don't let perfection be the enemy of good enough, right? Like A versus B lines is incredibly helpful, even if that's all you know how to do. Or Jamie Galen, I don't know if he's done one of these with you all or not, but like no one in the world should ever die of pericardial tamponade, because you can rule it out subxiphoid in like 3 seconds. So like if you just knew 2 skills in the world, subxiphoid, for a giant pericardial fusion, in A versus B lines. And then another thing I wanted to say is like, so in human diagnosis project, several people were like, yeah, but she had the sputum. But we don't often think about the side effects of what we're doing to treat people, right? So like she has B lines all over. So I still think that there's probably some fluid in the setting of known ischemic cardiomyopathy, and learning later she skipped her diuretics. But I still think that there's some component, and diuresing her isn't going to hurt her at all. Her kidneys were fine. Versus I feel like we throw on so many steroids and antibiotics. And so to me, this was a case of like, if I can use POCUS to like shotgun one less patient a week, that's also like good too. So again, don't let perfection be the enemy of good enough. I can chat briefly about the clue exam, which is my favorite way to tie together a cardiovascular exam. But yeah, Jamie, yeah.
Renee,
Okay.
I also want to add, what the beauty of this is, like you'd mentioned, by doing POCUS and seeing the B lines, if you do diurese the patient, you'll see those B lines actually become A lines, and then you supported your
Exactly.
hypothesis right there.
Exactly. So very cool study from Vicki Noble, who was actually, I cut the POCUS bug. We say that the branch of internal medicine that of the POCUS family tree, my little piece of it came off of Vicki Noble at Mass General during my residency, but she and some other people did this cool study with dialysis patients that were wet, and they watched the lungs as they dialyzed them and things. The B lines went away. So very quickly, if you want to do cardiac POCUS, I encourage you to either practice a ton and get really, really, really good, or have a construct, a way to think through it. So I will share just, we'll do like 5 minutes on the clue exam, which is my personal favorite, created by Dr. Bruce Kimura. He's down at Scripps Mercy. So the concept here is so he's a cardiologist. He also directs the echo lab. So he wanted the way to like assess for these very specific quick look signs. And you do the exam in the same order every time. You can do it in under 2 minutes, and he teaches it to all of his residents and does assessments. And so because he was a director of the echo lab, he was able to have the perfect gold standard, and his echo techs do a clue at the end of it. So they were able to validate the performance of these quick look signs, also that his residents, his internal medicine residents, could learn it. And then later on, tie that to, like for instance, patients in their hospital with left atrial enlargement had like worse morbidity over time. So I have a couple citations, and I can like attach this, or we can put it up. This was his descriptive paper in Journal of Ultrasound and Medicine. And it's a lot to take in here, but basically you just kind of sound it through. And if you think about it, you're going to work backwards down the pressure gradients. And this it helps me physiologically think about what's going on in my patient. So first of all, I look for the left ventricle. What is my left ventricle doing? Do I have cardiac dysfunction or systolic dysfunction? The left atrium, like poor man's diastology. If my left atrium is huge, something's been causing pressure overload over time. That doesn't happen overnight. Then he calls them ultrasound lung comets, but B lines. And just looking for them up here in the most specific places. Of course, you might have in a patient with poor lung volumes, you may have some B lines or something, but up here very specifically, and then look for, okay. So we made it from our left ventricle to our left atrium to our capillaries, right? And now the effusions, we're working our way back to our lymphatics. And then we're looking for subcostal. Is my right ventricle bigger than my left ventricle? So my right ventricular pressure. And then my IVC, my inferior vena cava, that's not an assessment of volume status. That's an assessment of right atrial pressure. We're trying to assess right atrial pressure with the IVC. So if we walk all the way through this, it gives us a really nice overall kind of sense of where the patient is. So I'll just maybe I'll just share these with y'all. So anyway, this will be a whole different thing. Maybe we'll do a separate one. But so I'm going to talk you through. I like to say we're trolling the wards. So with my students, we don't ask for pathology. We just ask for nice patients, because I just want patients that'll let us learn with them. And so sometimes I will ask their favorite song or artist, and we'll play Pandora for them, and we'll scan and teach them, and try to make it fun for everyone. That's also great for procedures when patients are anxious, telling you. So this patient, they say, go scan her. She's super nice, and she has heart stuff going on. And I like a puzzle, so I don't like to look before I go. So we go in and we scan my students. They're doing it. So we do a parasternal long axis. So her left ventricle, perfectly fine. It's pumping away. There's different ways to assess that we won't go into right now. Left ventricle doing awesome. Her left atrium, totally normal size. And then we're working backwards to the capillary level. and she's got B lines here. Okay, so now we have B lines. And then we come down to the bases, and this is a different patient, by the way, but yeah, so we come down to the bases and there's no pleural effusions. And then we come to the subxiphoid view. The right heart is big and the IVC is dilated and non-collapsing. So this is the high level. Does anybody want to venture a guess on just that clue exam? I'll pick on Vig. No, I'm just kidding. So, well, I'm going to be quiet for one more minute. I'll say it one more time, and then we'll see if anybody wants to venture it, and then I'll tell you what we guessed for her. So again, left ventricle totally normal, left atrium normal, B lines, no pleural effusions, a big right ventricle, and a dilated and non-collapsing IVC.
Yeah, so I guess I'm just gonna read whatever is mentioned in the chat. So I think a lot of people are mentioning PE. So Yaz has mentioned that. I can see Zara has mentioned it as well. And VJ is mentioning ASD and PE.
Love it. So sorry, I was too far up in the chat. So I did not see all of those chats. I love it. Thank you all for doing this. So how I would struggle. Okay, so I see Jimena, and so some people put pulmonary hypertension. So what we tied together. So of course I'm in front of the patient and I say, well, we're just gonna spitball here. I'm not sure, but B lines with this big RV makes me think about maybe some interstitial fibrosis and pulmonary fibrosis, and that causing like a pulmonary hypertension and a big right ventricle, elevated right atrial pressures, big IVC. But she didn't have like pleural effusion, which often go along with when we're thinking about volume, for instance. And so she pipes up. So basically I was like, I think it's probably like a primary pulmonary fibrosis with pulmonary hypertension and like giant. And she's like, it took them 2 days at the other hospital to figure that out. They actually had her on a dobutamine drip thinking it was like primary cardiac failure. Yeah, so Vig, temporal pattern is so key. And this is like, it's hard because, like you just show up and you're just trolling, but I just wanted to impart the clue exam as a way for me. I like it because it helps me think through the physiology and like the pump function. And then, yeah, so the IVC for right atrial pressure. Yeah. So, all these things could be their own lectures. Yeah, if you walk away with one thing, A versus B lines, look up the clue exam, and then that IVC, even the JVP, we're trying to assess right atrial pressure, and don't mix that with fluid status. It can be, but it's not always that. And I should stop talking and let you all talk, and any questions too.
Yeah, thank you so much for actually, sharing all of these amazing pearls with us. I guess I just had a question, because a lot of people were mentioning the PE, on the findings of the ultrasound you just mentioned. Would you say that there is one finding, that will help the most, in differentiating between PE versus pulmonary hypertension if someone is really caught in between?
That's an excellent question. So, probably a DVT scan. I mean, you don't have to, I mean, it's not like you have to have a DVT to have a PE or vice versa, but like that is one nice, easy thing. So there are things that you can look at, like there's something called TAPSE, which is tricuspid annular planar systolic excursion. And sometimes they'll even look at how fast it accelerates it. That's like high level stuff. One thing you could do is in your subxiphoid four-chamber view, the right ventricular free wall, it's like the little part down by the liver. If that is thick, that cannot happen over time. So the RV can be big acutely or chronically, like enlarged, dilated, but if the RV wall is thick, that's something that makes you think of a more chronic finding. But so much of this stuff is figuring out like what you can say and what you can't say and when not to overstep. And so I'm kind of just one of those like, keep it simple. But yeah, excellent question.
I had a question, Dr. Dversdal. You
Mhm.
mentioned you do simulation, and how do you incorporate your POCUS teaching within simulation?
Yeah, so we have a simulator that is it's like a body with, you have like your little fake ultrasound probe. Honestly, the sim center is best for the space for POCUS, like having a place to go and scan. So standardized patients can be great because when people are scanning on their peers, sometimes it's younger, healthier people. So we have some standardized patients that are up in their 60s, 70s, 80s, harder windows, a little more realistic. When you go over to the hospital trolling for patients, man, there's times where I asked like 5 patients, 2 are eating lunch, 1 has her family there, 1 is grumpy. And so it's sometimes I'll spend 3 hours and they won't get great learning. So actually Sim Center is a great place to practice if you're able and if they have machines. But mostly I honestly miss POCUS a lot. So I help out and I teach I still teach, POCUS stuff intermittently.
I just want to echo this has been great because we've been doing a lot of basic POCUS, so like B lines, A lines, CHF, P, but this I must admit, and a lot of the chat has been saying this is the next level, especially bringing clue and elaborating on it. I think this was highly, highly useful and taking it to the next level. So thank you very much. Anything else,
Fabulous.
Deborah, before we go to teaching points?
Yeah, I just want to highlight and say thank you so much for being with us. And I think as she's giving a lot of teaching for us, if she has like 2 takeaways that we should take from the session today.
Yeah, point number 1 is that no ultrasound finding makes the diagnosis for you, just like everything else, right? We are putting together a puzzle and we have to look at all the pieces. Teaching point number 2, I think, is just if you can just crush day in, day out, A versus B. So many of our patients have dyspnea, and I think we have a lot more wet patients out there than we know.
Thank you so much. I think we have.
Thank you all.
Thank you so much for being with us. It was a really good case and a lot of learning for all of us. Thank you so much, Yas and Ibrahim, for discussing.
Yeah, excellent discussion.
It was really great. And thank you so much, Jimena and Vijay, for the scribing and teaching points. So yeah, we cannot wait to have you back for another session, Dr. Dversdal.
Thanks so much. This was fun.
Bye-bye.
Take care. Bye.